Welcome to TSG Talk. TSG Talk aims to contribute positively towards the care of an injured casualty or vulnerable patient. If your goal is to maximise your input for the people you care for, then TSG Talk is for you. Our podcast will interview colleagues who are at the cutting edge of their professions. Often they're involved in creating solutions for areas that historically have proven difficult, or have a wealth of experience in a particular complex response. Each podcast will provide unique, engaging content. At TSG Associates, we will always strive to ensure our solutions are ahead of the curve and positively impact on the quest for prioritising survival and minimising suffering. We believe TSG Talk will complement our vision and provide a platform to enhance your response. It is my pleasure to now pass you across to our host, Senior Partner at TSG, Colin Smart.
Welcome everybody to the latest edition of our podcast TSG Talk. Tonight we've got a fantastically interesting subject. If we're dealing with multiple casualties who have got thermal injuries, then that can cause huge problems on how we resource it correctly to ensure that we get optimum casualty care for everybody involved. And often the resources of these incidents can be not just regional, national, it can often be an international response we need to get the correct level of care for everybody. So tonight we're going to look at the surge capacity involved in dealing with multiple casualties with burns. And we have a wonderful guest, Professor Randy Kearns from North Carolina in America, is going to be taking through this subject tonight. So I hope you enjoy it. If you do, please like and subscribe. A 5-star rating is always appreciated. So thanks for listening, and we'll be back again soon with another edition of TSG Talk. Good afternoon for me, Randy, but it's probably good morning for you in North Carolina.
It is. Actually, I'm in New Orleans now.
Okay, so still good morning.
It is. Yeah, it's 8 o'clock here, but yes.
It's fantastic to see you, and we were just having a bit of a preamble. It's probably 12-15 years since we last seen each other when I was across on your side of the pond. So it's absolutely wonderful to see you again, and thanks for taking the time out this morning to do this for TSG Talk. Randy, just before we get into the subject tonight, could you just give the listeners a little bit of your background, and then maybe talk a little bit about how you got into sort of resilience planning and more specifically burns at surge capacity?
Sure. So, I became an EMT and then later a paramedic in the late 1970s. I worked as a paramedic and then led paramedic organizations and taught paramedic programs for about 20 years. In the post 9/11 world, though, I earned a master's and then a doctorate, and went to work at the University of North Carolina, first for the hospital system and then for the School of Medicine, where I did research related to first of all, developing a medical disaster response team, and then again in the post 9/11 world, we realized collectively that we didn't have a lot of capacity for sea burning related events, and one in particular where we had a great deal of expertise at UNC. The University of North Carolina Burn Center, at least at that time, was one of the 5 largest and 5 busiest burn centers in America. So we had lots of experience, we had lots of data, and it gave us a chance to kind of focus in on an area that was certainly not well published and certainly not well understood at that time. So it gave us a chance to really look at it in a objective way, and what are things that we could measure, and then what are things that we could report so that others could learn from both our experiences and sometimes our mistakes.
Mm-hmm. Yeah. I think that's important. Learning often goes 2 ways, doesn't it? A good debrief is what we did do right, and then actually what we didn't do right, and how do we correct it. So I think that's hugely important. That's really interesting. So And I think we'll get from that is you've got 20 years on the road as a paramedic, so you're really coming in from hands-on. Then you've got all your academic experience to doctorate level with your multiple publications, and obviously specifically looked at this issue of burn surge capacity. So it's quite a career that you've had and continue to have. So yeah, quite amazing. Just looking at the issue of thermal injuries and burns injuries and being able to resource these correctly. Why is it a problem? Is there major differences between multiple casualties with burns injuries to what we would class as our sort of standard multiple casualty incidents with maybe blunt and penetrating trauma? What would be this thing? It's sort of things that set it apart, and why we should consider it as a unique area to look at.
So there's two concerns. The first concern is, if you think back over your career of caring for patients and you think about the number of times you encountered somebody with a burn injury, that number, that N is small. And so on an individual basis, we feel less comfortable taking care of patients with a thermal injury or any type of a burn related injury. And then the second piece is, okay, let's compound that to now we have 5 or 10 or 50 or 100. Um, and then the downstream resources that are available for us to, from an EMS perspective, take our disaster to the hospital, so to speak. What's their capacity to deal with it? In traumatic injuries, if I think back to my times answering calls, and although that was many years ago, the reality was, we saw quite a bit of trauma. We saw, quite a bit of medical emergencies, cardiac related emergencies. And so you built a lot of muscle memory out of that. There were a lot of almost instantaneous things you could do that you felt very comfortable doing. With a single burn injury, if we look just at the data, um, as a profession, both in the pre-hospital world and the community hospital world, we do a poor job of assessing the size of the burn. We do a poor job of understanding the depth and complexity of the burn. And we do a poor job of treating the burn. We tend to cool the area too much. We tend to infuse too much IV fluid. Um, and so that's with one patient. And so the compounding effect of having a mass casualty incident related to that um, can be quite significant. And then downstream, where do you take those patients to? You know, the American model of healthcare, at least for us, is more of a function of capitalism. It's supply and demand. If there
Mhm.
was a demand for, you know, 5,000 burn beds, we would have a supply of them as long as there was finance to support it. But the reality is, on a day-to-day basis, there's a demand for about 2,000 beds, and that's what we have for a population of about 350 million people.
Mhm.
And so, there are realistic scenarios that could produce 500, 1,000, 5,000, 10,000 burn injuries. And then, how would we manage that? And again, the compounding effect of the throughput times, how long would it take for us to manage those patients downstream? It's really a complicated and complex problem that's, again, I get back to, if we struggle to deal with one patient, we're going to have a monumental task dealing with many of them.
Mhm. Okay, no, interesting. And it's interesting what you say with your capacity for Barnes beds. You've got about 2,000 in the US for about 350 million people. And I mean, I don't have the data off the top of my head, but I know the ability to access high dependency Barnes beds in the UK is limited. And when I often talk to emergency planners about this area, they often refer to it as being not just a national incident, possibly an international incident. So it's the one thing I seem to get from the ability to manage burns as we evacuate them to try and get definitive care for them is that we tend to have a plan that spreads the net really wide. Would that be similar to the experiences that you've got?
It would be. Now there are other, there are other challenges with that also. Um, there are, we kind of stratified it into three types of events. One type of event is just a mass casualty event with a lot of burn injuries.
Mhm.
An example of that would be we had a chicken plant processing fire in the early 1990s that produced about 50 patients with another 25 deaths associated with the disaster. But all of those patients had a burn injury. And so when all of your patients have a burn injury, it's a lot easier for us to figure out, where to route those patients to as far as burn centers and burn capability and capacity. Um, and then there are those events that have concomitant injuries where there's both a traumatic injury and a burn injury, such as a substantial blast. And when there's, some type of an explosion, trying to be sure that we're using trauma services as well as burn services. And the reason that is a compounding problem, when we have just a mass burn casualty event, um, we can pull from trauma resources to help us manage those burn injuries. When we have concomitant type traumatic injuries, the thing that's going to kill you first will be the traumatic injury, the
Mhm.
exsanguination. So,
Mhm.
the trauma folks are going to be busy dealing with patients with trauma injuries, and so we don't really have anything to pull from to help us with our burn injuries.
Mhm.
And then the third and really the most complex situation would be where something has occurred that's also damaged the infrastructure, such as
Yeah.
an earthquake. Um,
Mhm.
if it damages the infrastructure, it may damage the building that you use to primarily take care of your burn injuries. You may also have challenges with how you're able to move patients, again, because of damaged infrastructure. So the simplest is just a mass casualty incident with burn injuries. A little bit more complex is concomitant injuries. And then even more complex is where you have damage to the infrastructure.
Mhm. And I suppose if you want to throw another complexity into this, if you put pediatrics in, it becomes, I think what you pointed out a few minutes ago was we don't do this very often for probably adults, but how often do we do it with, well, you might actually see it a few more in kids, just given maybe the nature of some of the incidents in houses and things. But I suppose you then throw the complexity of trauma, pediatrics, and burns in as well, and we're now getting really complex. So,
It really is, and dealing with children, it takes on its own level of urgency. Again, our inconsistencies in how we care for those patients. And just honestly, from state to state here in the US, we have different definitions um, of what a pediatric patient is by definition. What's the age group? And
mhm.
then the age group and then the size of the patient, may tell us we need to treat this patient as an adult,
Mhm.
even though age-wise they're a pediatric patient. So
Mhm.
I can tell you just in terms of stratification of what a pediatric patient is by definition varies from burn center to burn center and state to state.
Mhm.
We, again, I think our first focus is trying to get a handle on how we would deal with kind of the mass casualty event in general. But yeah,
Mhm.
if there's a significant number of pediatric patients involved, the N of availability of the types of resources we would need for the care of those patients is really, really small.
Mhm. Yeah, interesting. So I suppose your assessment of what you're dealing with is going to be really important at this point. And I think just to bring that point up, one of the experiences we had in the UK, we had a tower block fire probably quite a few years ago now, called Grenfell Tower, where the cladding lit up, and
I remember it.
it's a very significant fire. But I remember I talked to the emergency planners at London Ambulance Service about it, and I was expecting a debrief from them that would talk about how they dealt with Burns casualties. But what they said was they had hardly had any. But their casualty load was airway problems. It was all inhalation. So I think that brought a point out to me. Although you're looking at a high-rise building on fire, and your initial assessment is I am going to have burns injuries, it didn't. become that. And very quickly, it became that they had airway problems and they needed to really get their heads around switching from thinking injuries to skin to injuries to airway. So it doesn't seem to be an easy thing to assess. I think it's trying to work out the mechanism really quickly and then work out the complexity of the resource that we're trying to organize would seem one of the complexities on this one. I don't know if there's any magic answers to it apart from understanding that this is a problem.
Sure, sure.
Yeah.
Well, and you bring up inhalation injury. I'll tell you that the data tells us that we have a tendency to intubate too many patients with an inhalation injury. But I can also tell you the flip side of that is if you don't get them intubated at a time before laryngeal edema begins to become a real problem associated with an inhalation injury, somebody's going to wind up getting trached. I mean, it's a really delicate balance. Do I intubate someone or do I not? And from a paramedic standpoint, it's a difficult call. Again, retrospectively, looking back on the data and the patients, the numbers tell us we tend to intubate too many patients with a inhalation injury. But again, the compounding problem with that is if we don't intubate them early enough, we're going to miss that opportunity to get them tubed and then really compound the problems that we're going to see with the patient downstream.
No, interesting. Just moving on from some of the complexities of dealing with this type of incident, you brought out a really good example of the chicken plant with 50 patients, which was primarily burns. I often find people really learn well from experience and stories that you may from experts like yourself, the what you've encountered. But are there any stories where you've picked out maybe what works and often that's important, what doesn't work
Sure.
that we can learn from at all?
So probably a couple of more recent experiences. We had an explosion of a food processing plant. They were changing out a gas heater or a gas water heater. The residual gas that was in a very long line was allowed to seep out into this confined space, found an ignition source, and exploded. The explosion in the fireball was a food processing plant outside of Raleigh, North Carolina. Created several dozen injuries, but 7 of them had some type of burn injury. 4 of them had critical burn injuries. Just with those 4 patients. Now, 3 of the 4 patients wound up were immediately transported to the burn center, had really appropriate EMS care from a paramedic viewpoint, and all 3 of those patients wound up in a surgical suite within an hour of arriving at the burn center. So all of the things that, kind of all of the boxes that you're trying to check were done well. And actually that 4th patient was also done well. There was a concern of concomitant trauma. And as I mentioned before, the biggest, one of the larger challenges we have with patients during an explosion, as an example, the distracting injury can be the burn injury. It looks really bad, but the first thing that's going to cause this patient to die is the exsanguination. So, we have to clear them of the traumatic injury first. And there was actually a level at that time, a level 2 trauma center. I think it's now level 1 that was actually closer, but did not have a burn injury. I'm sorry, did not have a burn center. The patient was first taken to that trauma center, cleared of the traumatic injury, and then moved on to the burn center for burn care. And then 3 more burn patients had burn injuries, but went to a community hospital first because they were less than or equal to 20% total body surface area burn, and then were transferred on later on that evening. The main takeaways I would give you with that is, coming to what was a really large burn center. At that time, I don't work there anymore, but it's and a very well-prepared burn center, 4 critical patients was a lot. We could have probably handled another 2, 3, 4, but if the scope is 10 or 20 or 30 or 50, the triage of that and trying to assign resources, um, can be really challenging. Other things that I would tell you just from a hospital standpoint, um, we had at that time, I think we had 38 burn beds in the hospital. I always, it's a state hospital, so I always joke about the fact that we had 45 patients on the burn service at that time.
Right.
And 45 patients and 38 beds means we're putting 2 to a bed. That's not true. But what that means is we're borrowing beds from other service lines, other critical care areas. And so immediate bed availability, and one strategy for immediate bed availability is having somebody go through and triage all of your current patients and look for who can be transferred out so that we can free up some bed space for what we know in the next hour is going to be an incoming group of patients. And so the first thing is having somebody who can help do that triage. In this particular case, it was one of the burn surgeons who went through to sort out who could be moved, who could not. And then the second group that is often overlooked, but that's housekeeping. We've got to clean that room and prep that room for, the next patient. So, infection is a ever looming problem with burn injury. And so being sure that the room is appropriately cleaned and sanitized and ready for the next patient is a skill. And again, we don't always look at housekeeping as being an important part of the mix, but they really are. We're trying to quickly turn over beds and get into an immediate bed availability situation. But our and one of those patients died at about day 69. Complications associated downstream with infection, but in general, outcomes for 4 really critical burn injuries, 3 of which had what I would call a walk-away type success story. But all of the pieces worked. EMS did an outstanding job of caring for the patient's bedside, did an outstanding job of triaging patients, got lines started, IVs infused, did not over-infuse the patient. In EMS, we sometimes have a tendency, 1 is good, 2 is better, 3 is got to be great. So, it's probably what led us to use high dose at some point, but, we typically teach a staggered amount, 125 cc's an hour, 250 cc's an hour, and 500 cc's an hour for an adult patient with a burn injury of greater than 20%. 500 cc's an hour kind of sounds like a lot, or 500 mLs per hour sounds like a lot, but I've seen people with 3 liters infused by the time they arrive at the hospital an hour later. And 3 liters and 500 is, there's a difference there. We may overhydrate the patient and create some downstream problems for that patient.
Yeah.
But anyway, EMS did a great job. The hospitals close by did a good job. The ones that saw patients initially helped us with a buffer in terms of we're able to hold them until we could clear some beds for them. But if we had 20 patients or 30 patients or 50 patients, we'd already called the next burn center over, which was over at Wake Forest University, and they were prepped and prepared to receive some patients. We didn't wind up with enough to wind up sending them some, but downstream, who do you call? Who else can help you? And then obviously, how are you going to be able to move patients there? What type of system do you have within your state to be able to, or within your government body to be able to move patients over greater distances?
No, well, there's some really fascinating points from there. One thing I'm picking up on is the triage is going to. The triage comes at 2 ends. You've got the point, the sharp point at the incident where we're trying to triage. So if we take for the example, say we're dealing with 20 moderate to seriously injured burns people with limited capacity to maybe definitive or certainly supportive care. The triage there, given what we've talked about, that your average pre-hospital provider's probably got limited experience in this.
Right.
Burns himself are a distracting injury, and there could be trauma involved. So the triage of who we're going to evacuate to where is actually going to be very skilled. Have you got, and we'll talk about the triage at the back end in a minute, but have you got any thoughts on should we be getting an expert there as soon as possible, or is there any way we can use virtual um,
Sure.
what's the word I'm
Telemedicine.
looking for? Yeah,
Yeah,
I'm just
telemedicine.
trying to think. It just seems we're dealing with very complicated casualties with the very limited resources to send them to, and something we don't deal with an awful lot. What's your thought about the level of expertise we should try to get to the scene to try and get that triage right? Because that would seem a critical part of trying to maximize survival from where and minimizing the suffering and also making the assessment, can we hold this person for a certain time and still maintain the correct level of care and still maximize the survival chances? Any thoughts on what we need to resource to get that triage right? I don't know if there's a right, if there's a, is again, is there a perfect answer to this, or is there what would be the best you could suggest?
So, to be honest, the reason triage worked so well in that event, um, about 30 minutes earlier, they had a 911 call of a passenger train struck a vehicle.
Hmm.
And so what that allowed them to do was they had already called up the cavalry, so to speak.
Hmm.
A medical director and a second medical director had already been activated. They were in cars and had responded to that event, and they were clearing that event. So there was a physician on scene
Okay.
who is one of the best ER docs I've ever been around. Actually, Dr. Brent Myers, that
Okay. Hmm.
probably know the name, but he was the one on scene doing triage. So
Yeah.
to tell you it went well, maybe we cheated a little bit just simply because we
Correct.
had some of the best skills in the
Hmm.
house. But how do you replace that is a really good point, because it does take someone with good triage skills to be able to help sort that out. Places I have seen that work is with the, we tend to call helicopters, again, at least here in the States. And if we call a helicopter, can you send someone with you
Mm.
that can help with this type of service? There, in 1994, there was a really substantial um, non non-conflict related incident at Fort Bragg, um, where a fighter jet crashed into a C-140 or C-141 that was loading airborne troops to go do a drop.
Mm.
Killed 23, injured another 100. Um, and they sent a physician from Brooke Army Medical Center to Fort Bragg to help with triage and decide how many patients they were going to wind up taking back to Brooke Army Medical Center, which is the burn center uh, for the U.S. military.
Mhm.
Um, having a physician is certainly ideal. That's not reality for many of us in the EMS world.
Mhm.
So how do you replace that? Telemedicine, I think, offers that next best
Mhm.
opportunity. Your most skilled person, though, to do triage really is going to vary from organization to organization,
Mhm.
but it really does need to be somebody with good skills.
Mhm.
Can we lean forward and send you somebody in the helicopter? That's a possibility.
Mhm.
Can we use telemedicine? That's a possibility. I think everybody needs to evaluate what their resources are and make judgments based on that.
Mm.
Um,
No, really, really interesting. So I think what I'm getting from that is that the triage at a multiple burn scene is going to be difficult, and the
yes.
quicker we can access somebody who has got very good knowledge in this area is going to be important for the overall outcome of what we're going to. And every situation is going to be difficult. The fire in London where we've got very close concentration of multiple trauma units and the trauma system in place is going, you may have easier access, possibly not, but more chance you will. You go to a more, say we're going now, rural North Carolina, you might never get that physician, but you may be able to close that gap by thinking about telemedicine and putting that into your plans. So I think it's, I suppose what we're saying there to our colleagues is think about how you could access that information to assist that role, because that role is going to be really important. Would that be a fair summary of what we were trying to get to?
I think that's, yeah, spot on. And you may be working with a burn center that routinely sends somebody out that could help you with something like that. But in most cases, they don't have the excess manpower to be able to do that.
Mhm.
And so, your next line is really telemedicine. And certainly with the technology we have today, that's far more of an option than it's ever been.
Mhm.
Um, but you're right on point though in talking about triage is the tipping point of how we get this started correctly. If we can do that well on the front end,
Mhm.
it makes things downstream work a lot better. If
Mhm.
we're having to catch up for that or compensate for mistakes made in triage or patient care, it creates a compounding problem for the patient or
Mhm.
patients.
Yeah,
Yeah.
and very interesting, and I think it's a hugely important point for anybody in the planning phase to consider. The other point I picked up when you were talking about the triage is, and it sounds like you have very similar circumstances to the UK at the moment, where our health service is going into winter pressures, where they are bursting to capacity. I mean, on a normal, even on non-winter pressures, with the national system, we're already pretty full. So you're right, we're looking at healthcare facilities trying to surge that are already at capacity and already have patients. And I think anybody who knows the subject, there's no point taking a seriously injured patient to somewhere it's already full, because we can't give optimum care. So I think what I'm picking up from that is any part of a burn surge capacity plan has got to understand that there's back end triage at the receiving facility. And again, somebody of the appropriate skill has to be available. I mean, I think we use the phrase here, it's rapid discharge triage, that we can implement. But that sounds a very important part. So when your patient does turn up, there is the right skill and the right space for those people, because this is a limited resource that we're dealing with. So something what I'm picking up from you is very important in the planning phase.
Yes. Yeah. The uh, so so my research, my doctoral dissertation actually dealt with building a computational model to look at what our capacity was, at least under conventional surge capacity standards and conventional standards of care. Um, I mean, to be honest, the southeastern U.S. we can absorb about 500 patients. The tipping point was about 435, and what that tells us on a broader scale is there are real world scenarios where typically conflict related, but in the post 9/11 world, and particularly in the world we live in today, where conflict is at the doorstep of a number of countries, um, you know, if we wind up with thousands of patients with burn injuries, we're truly going to overwhelm the system for, even if we somehow magically wound up with enough caregivers,
Mhm.
we don't have enough specific supplies to take
Mm.
care of those patients long term. The types of skin substitutes we need, the types of um, dressings we need for optimal care. Um, there are a lot of supply chain type
Mm.
items that even if we could magically produce enough caregivers and there were enough beds to take care of 10,000 patients, we don't have enough of the specialized supplies to do the same quality, to predict, create the same type of quality outcome that we can predict right now with one patient. You
Mhm.
know, one patient with a critical burn injury who's relatively healthy with no comorbidities, we're going, and we take kind of an all the king's horses and all the king's men approach. We can typically put that person back together,
Mhm.
um, rescue, resuscitate, rehabilitate and resurface and help them through recovery to the point that the person that they see in the mirror today, over time, will look a lot like the person they saw before the injury. Um, and all of those things are important in the burn world. But when we're dealing with one patient, we can do that. When we're dealing with dozens or hundreds or thousands, the trailing point of how much of that we can do really goes away quickly.
Yeah, and you've brought out a really interesting point. Sort of running a business as I do, most businesses run on an understood flow of materials, because if we hold too much, it affects what every industry and every business is vital to its survival, is its cash flow. We can't hold too much stock. That stock's got to be moving. And outside of the burns world, when we've looked at all this, the recent conflicts and where we've had to like surge a lot of medical equipment going into Ukraine, one of the problems we found is that industry takes time to react, because most of us are working on just on time resources and logistics chains. So I think that's a really important problem. If we suddenly introduce 500 complex burns cases that we've managed to do a really good job at the front end, and we've kept these people alive, the long-term issues are now hugely substantial. And industry is going to have to take time to react to bring that amount of equipment on, because, and I think even as it gets more specialized, there is a capacity to what industry can do. I don't know any industry unless they're under some specific law that will stockpile, because the laws of business won't allow us to do that. So we have so much dust and time to run efficient financial institutions. That's what we basically are. So I think that's important, that the resourcing doesn't stop once we've done the initial life saving. It's a very important point, and I suppose that's a massive part for planning. To think, what are the if we had this extra input of casualties into or patients into our national system, is there ability to resources the long-term care of these people to get the outcomes that we actually want? It doesn't stop 40 hours afterwards, does it? That's also really interesting. The last podcast we did, as we talked about, just as we were sort of pre-chatting and a pod with the hospital, Rexford Hospital, evacuated in Ireland with a complete hospital closure. One of the points Mary Rose Fitzgerald brought out was, it's a very long-term thing. We have the initial, we have evacuated the hospital, but now we've got 9 months of patients now being 90 miles away from where they should be. And all the staffing and all the resourcing and the shutting down of the facilities in that local area, it doesn't stop 48 hours afterwards. There's the ability to continue treatment in more remote areas with the limited ability to maybe immediate equipment that we need could be reduced. So I think that's something that the long-term resourcing of mass casualties burns is it's your subject. It's fascinating, but it's a major one to consider, I would think, just given some of those dynamics.
Well, and the reason they're so important is the reason we have the types of outcomes we have today is directly related to some of the resources we have. And so if we limit those resources, again, the best skills in the world, you're still going to have those diminishing returns, the diminishing types of survival numbers that we see. We have published a couple of papers related to the larger the number, the smaller the triage scales. We produced the American Burn Association produced a triage table in 2005. We republished it considering inhalation injury in 2014. In the latest version of that, version 3, we published in 2020. And in that, we actually looked at surge capacity in the context of the burn world. In traditional surge capacity, we think of conventional contingency and crisis standards of care. What we came to realize thinking through that was there's actually a fourth window of time, and that's a catastrophic event. Again, where you have thousands of patients. We'd previously written a series of papers about austere care, how to care for burn patients when you don't have some of the resources you have. But what really brought this into focus is, again, if we've got 50,000 patients and under ideal circumstances, we may be able to absorb about 2,000. What are we going to be able to do with the other 48,000? And how long is this going to be a catastrophic event? Did it interrupt supply chain? Through the strategic national stockpile process in the American model of healthcare, we've at least built a little bit of that buffer in there, but it's small. And so it doubles your number from 2,000 to 4,000. There's still 46,000 that you're not taking care of in a scenario of 50,000. And so there's going to be a catastrophic window of where people will have normally survivable injuries who probably won't be able to survive just simply because of our lack of resources or personnel or space to care for them. And it does dramatically alter what types of outcomes you can set expectations for, again, because of supply chain and because of how much access or limited access to care we have.
No, and very, very, very interesting. The other thing I'd like to pick up from one of the areas you covered, which I thought was really interesting, was that you obviously mentioned infection kills people's and burns, and the ability to clean a treatment area for burns is quite a skilled thing. The reason I wanted to bring it up was I helped run an exercise in one of our local trauma centres, and we were talking about hospital evacuation, but where we could hold people for a period of time before we got all the communications about where we were going to send them, what transportation, what escort type of skills required. And one of the things I raised with the people planning the sort of the holding area for the casualties prior to transportation away from the hospital is how many janitorial supplies they would require. And it was really interesting when they started thinking about it, because their thinking was that their first thinking about supplying that holding area was all the technical medical equipment required to support that patient's care. But when we raised the issue of cleaning the area and the most simple things, you could see in that experience they hadn't really thought it through. But then when they started to work out the volume of equipment they would need, it was quite substantial. And you could see the little light bulbs coming on. So I just wonder if that is actually a major part of burns planning is for your units. If you're having to bring one patient into a resuscitation burns bay, then move them out and clean it down, and that will take a volume of equipment. I just wonder how much planning needs to be thought about. Do you have enough equipment to maybe, I should say, with the trauma centre you talked to, you said you're getting pretty full at 4. If you have to process 10, how many basic bits of cleaning stuff do you need to clean that area so we reduce the infection? It's quite unique to burns by the looks of it, isn't it? There's going to be a lot of stuff.
Well, it is, and there's been a lot of focus on what we call hospital-acquired infections here in America in the model of reimbursement. In fact, you can lose money if you wind up with patients admitted for a heart attack who wind up with a MRSA infection, as an example. So, not that everything revolves around money, but again, in the American model of healthcare, capitalism is certainly a cornerstone of it, and so the best way to tie reward and punishment is to reimbursement. And so ideally, people are doing things for the right reason. And as we're thinking through what the right reason is being sure they have a clean, germ-free environment that they're moving into when we're moving patients into there. But there's also a reward for that, but there's also risk for not doing that. So no matter whether you're doing it for the right reason or you're doing it for the monetary reason, there's a motivation to be sure it's done well, and that's being sure that your patients are moving into clean spaces. And for burn care, the largest system in the body is the integumentary system, the skin, hair, and nails. And when we lose big portions of that, we lose our ability to thermoregulate. So typically these areas need to be warmer. If you've ever been in a surgical suite during a debridement surgery, the OR temperature may be 98 degrees. It's not unusual for burn surgeons to work in an area that's, typically a surgical suite is, again, in Fahrenheit, it's 65 degrees or 70 degrees. In a typical burn surgical suite, it's going to be in the 90s. Because the patients lost their ability to thermoregulate. So you lose that. You also lose that protective measure that goes with it. So it's a lot more likely to be exposed to infection. So it's a complex problem that really starts with being sure they're in a clean environment and they stay in a clean environment.
Yeah, and as I say, and to clean that environment, we'll take a level of equipment, and if we have if we have the potential of 10 people going through that, we're going to have a stockpile somewhere, because if we run out of equipment, we're compromising the ability to have that clean environment, which is planning, isn't it? And preparation and assessment and everything that goes with it. But as you say, for burns, it is literally life-saving to have this area clean. It is.
Absolutely.
I mean, I think there's some areas in healthcare we can compromise that, because we say, yes, it's not a clean air, exactly clean, but we can do other things. But with burns, I would say if we're looking to maximize survival, we can't compromise on that. It's a must. So I think what we're picking out here is some of the uniqueness of what we're coming with dealing with multiple casualties and burns. That's really interesting. Just if you were to try and give sort of 3 points to help colleagues try and plan for these events, or think about what are the main things they have to consider when they're trying to get a grip on a plan, or even audit their own plans, did you have a sort of top 3 tips that you could give based on your experience?
I would start with one. If we're competent and confident in caring for one patient, there's scalability to that. But the challenge we have is rule of nines. Can you rapidly assess the size of someone's burn? Can you rapidly assess the degree of someone's burn, whether it's partial thickness or full thickness? Sometimes we'll call it a second or a third degree burn, but can you accurately assess the nature of the burn, the size of the burn, and then develop a care plan? How much fluid do we infuse? How do we cool the injury? All of those things, I can tell you the data continues to say that we do that poorly. So if we can focus on caring for one patient with a burn injury, there's scalability to that. But if we can't do that well with one patient, we're probably not going to take care of 5 very well either. So it really gets back to, can you assess the size of the burn accurately? Palm of your hand, if nothing else, palm of the patient's hand, can give you 1% for size of the burn, or rule of nines will help you. The challenge with rule of nines is sometimes I tell somebody, well, the whole arm is a 9. And so they have a small injury on part of the arm, and they account that for 9%. It's no, it's a percentage of the 9%. And then depth of the burn. Is it a superficial burn? Is it a partial thickness burn or a full thickness burn? We typically get that part closer to right, although sometimes, again, we can get confused over a superficial burn. So my big 3 things would be, can you assess the size of the burn? Can you assess the type of the burn? And can you appropriately initiate care for that burn? And I guess the 4th piece, or the 3rd piece, splitting in 2 pieces, caring for that burn, is cooling the burn to be sure you've stopped the burning process. But again, sometimes we have that attitude of 1 is good, 2 is better, 3 is best. So we really make it cold.
mm, mm,
That's going to the extreme. We want to be able to palpate the area contiguous to the burn, and it's warm to touch, not cold, but not hot.
mm,
Um, we've got to stop the burning process. So that's the first piece. And then cover with a clean, dry dressing, whatever you put on it. Just
mhm,
understand when you get to the burn center, we're going to take it off and debride the burn. We're going to remove anything around the burn. So whatever you put on is not terribly important as long as it's covered, again, clean, dry dressing, um, and then the right amount of IV fluid infused. If you've got a large burn greater than 20% total body surface area, infuse half a liter an hour, and let's go to the burn center. Again, we tend to infuse too much fluid. 500, half a liter an hour is still a lot of fluid, but it's not, we're not going to dump 3 liters in a patient
mhm.
before they get to the hospital in an hour.
Yeah. Mhm.
Um,
Okay. Okay, really interesting. So the big thing I got from that is the foundation of every Burns plan is about the individual being as confident as possible with dealing with the individual patient. And if we have that right, it's like all plans are built on solid foundations, and that is the foundation of what you need.
right.
So, yes, there's a lot of planning, a lot of logistics, a lot of really complex thinking, but at the most basic level, we've got to get the stuff right. So let's get good
Right.
at one patient. And we know there's complexities there, but if we know that, then we can put training programs in place to help that. So we have that as a foundation. I really like the phrase that you use about how much you cool a burn. And the reason I picked up on that is obviously hypothermia is a subject I'm really interested in. But as you know, hypothermia and burns patients are a real balance when we're looking at cooling, and we've lost that thermoregulation. And I think I picked this up right, but please correct me if I haven't. Is that you said that the site of the burn should be warm to touch, not cold, not hot. Did I pick that up correctly? Because I
Yes.
think that's a really good phrase to hang your hat on.
Yeah.
So you can try and gauge, am I cooling too much or have I not cooled enough? Am I keeping my person as normothermic as possible or am I going too far? Because I think it's difficult, isn't it? But I think that's a phrase it would be worth passing on to more colleagues to give them a gauge on how they're doing it as correctly as possible.
Yes. And you can, again, we can palpate the area contiguous to the burn site, the uninjured skin.
Mhm.
And if that's warm to touch, you've probably done what you need to do.
Okay.
It is important to stop the burning process.
Mhm.
I will tell you that again, there's data that tells us sometimes we don't do that. We kind of skip to some other things. If you don't stop the burn, it's going to continue to expand the size of the injury. So you do have to stop the burning process.
Mhm.
But then again, what's enough? Enough is being able to feel the area next to the burn and it's warm. And we've stopped the burning process at that
Mhm.
point. Then fine, let's
Mhm.
wrap it up with a clean, dry dressing and start our IV and let's get the patient to
Mhm.
a burn center.
Okay, interesting, interesting. Good.
One, one
So, sorry, Andy.
One other piece I did want to mention
Mhm.
is pain medication.
Mm,
The pain medication administration for a patient with a burn injury. This is not an MI. With a myocardial infarction, we typically use small doses. Um, I'm, I'm, I'm thinking back in an old school sort of way,
mhm,
2 milligrams of morphine.
mhm,
You know, we have better painkillers today, but the point is pain management with a burn does require more resources on hand for long transports. So the amount of pain management you may need for a burn may be substantially greater.
mhm,
You know, again, we need to monitor the airway and be sure that we're not knocking out their respiratory drive,
mhm,
but we also need to manage their pain, and the pain associated with a burn injury can be quite profound.
mhm, mhm. Yeah, it's one of those balances, isn't it? It's you've got the seriously injured person, all the complexity of what the burns does. There is intense pain, but there's a real balance to how much you have to manage that pain as opposed to the contraindications you're going to get to the pain medication. Um, and again, I suppose that goes back to being confident with your individual patients and
Right.
understanding it. So when you
Right.
have to do it under multiples, then you're coming back onto good solid knowledge. But yeah, it's certainly not a one-dimensional thing that I just put a bolus of, a high dose of strong analgesia, and there's a lot to think about on this one. It's
Exactly.
complex. No, really interesting. We have one more question to ask you, but let me try and summarize some of the main points we brought out because I think there's some absolute gems we brought out that will be really beneficial to everybody listening. So some of the things I've picked up is that one of the fundamental problems when we're looking at dealing with multiple casualties and burns is that the burns injury themselves is not something we see an awful lot of in pre-hospital care. So it's very difficult to be a sort of true expert because we just don't see this that often on our daily workload. It tends to be every now and again, as opposed to the stuff we do every day. So there's always the ability to have the real detailed knowledge on the road of the responders can be limited. We can, as long as we understand that, we can do something about it. But that tends to be one of the issues we're dealing with. And I think you summed up real well some of the all burns injuries aren't the same. We can have an incident that is just burns, which gives us one set of dynamics. We can have another type of incident where we've got burns plus trauma. Um, and understanding there is that the burn can be a very distracting injury. The burn may not kill someone, the trauma will, but we may be distracted by just the visual effect of the burn, and that's something to bear in mind. And if it's at burns versus trauma, it's trying to work out what's going to kill the person first. That's where the intervention should come from. And then the interesting one we talked about is that one of the complex areas in burns is where the actual local infrastructure is affected. So if we're looking at uh, massive explosions, I suppose something like we've seen in Lebanon, where the port exploded and took out the geography of the area. I mean, I don't know what medical infrastructure it took out, but there wasn't a lot left standing. There are going to be occurrences where our local burns facilities are, your very large hurricanes, your tsunamis, that's going to take medical infrastructure out. And that's something based on your risk assessment we're going to have to think about. So definitely one burns incident is not, they're not all equal. There's definitely things to consider within the planning phase. Um, Small numbers of burns patients will stress big facilities. I think the point I picked up there was when you were dealing with the four patients on the incident that you talked about in a large facility, it was already stressing the system.
I see.
So fairly small numbers of patients will stress out facilities. One of the keys to trying to manage that is triage at the pointy end where it's happening and trying to get the level of expertise into there as quick as possible because it
Right.
will be complex triage, but also having triage at the receiving facility to make sure there's clearance of facilities to receive the casualties that are being triaged. So I think understanding there's access to information at the scene, but really good triage at the back end to make sure we're clear. Understanding that most facilities, I think worldwide, are full these days. There's not many empty hospitals floating around with staff ready to receive. If there are, could you please let me know? I
Yeah.
would like to go and live there. So that's quite an interesting one. Um, Burns themselves require long-term treatment, and if we're truly dealing with mass casualty burns, they may be supply problems. There's going to be a lot of consumables at the first 24 to 48 hours. But if we're looking at injecting hundreds of serious burns patients for long-term care, there's a lot of very specific treatments that have been developed, and there just might not be a surge capacity for industry to understand that. And that may be something when we're looking at our long-term planning, which is something I picked up from the hospital evacuation podcast, long-term planning is got to be considered as a major part of your plan and not just the first 40 hours. It's a big thing to consider if we're trying to optimize outcome. Just the amount of equipment. Infections kill people in burns, and I think if our aim is to maximize survival and minimize suffering, which I think is what we're all trying to do, we know infection is not. We've got to avoid it, and we know if we're going to bring a serious burns person into treatment facility, it's got to be scrubbed down to a very skillful clinical level. And if we're trying to deal with 10 patients going through that facility, that's going to take a lot of kit. And if we run out of kit, we're not going to be as good as we should be. So there's a planning thing there to think about as well, which I think is very important from a planning phase. Um, Pain management, as we've just talked about. is not one-dimensional. It's going to take a level of skill to get that correctly, but it's very important in what we're doing. And I think the last point I brought out really well is where you say one of the fundamentals of getting your plan right is to be comfortable with your single patient. We know assessment of the burn is difficult. It's a complex injury, but I really like the phrase that you brought out, where we're trying to get the correct level of cooling, and especially pre-hospital where our monitoring may be of a restricted level, where we can warm to touch, not cold but not hot. Because as I say, the complexity of taking your burns patient hypothermic is really starting to mess the physiology up of everything we're trying to do here. So I do like that, and I think that's something first, pre-hospital responders and to degree early hospital responders could probably get a hold of to help them make that judgment, which is quite important. So that's my summary. Have I missed anything?
No, you haven't. I will tell you, we did a survey of EMS personnel and emergency department personnel in North Carolina in 2014, and we found about 63% of the respondents who had more than 10 years of experience felt either uncomfortable or we actually gave them the option of scared to death as a choice in dealing with a burn injury. And
Mm,
so if more than 60% of the people who routinely work in emergency services, either the hospital side or the EMS side, feel uncomfortable dealing with a burn injury, the point is you're not alone,
mm,
but the point is also, we need to do something about it. We need to, what are courses that are available? What are things that we can do to make
mm,
at least put us in a position where we're more comfortable dealing with these types of patients? The number of burn patients you'll see in your career as a paramedic or even as a physician in the ER, that number is really small,
mm.
but it's still a number.
It's
And
still a number. Yeah.
yeah, and so we do have to think about how we're going to take care of those patients. What are the resources we have, and who do we call to help us?
Yeah. And I think what I'm picking up from that is that if we understand that, we can do something about it. We may not have the perfect solution, but understanding that the level of skill we're bringing has got a reduced level of experience on it. That's okay as long as we understand that and we can put supportive measures in place or training methods in place and things to incrementally improve. But if we don't understand that, we may be working on a false sense of security that we can deal with it. So, and I think for any planner, and I think the big thing I've picked up from this is the fundamentals of any successful burns plan is to be comfortable with the individual patient as early as possible. Yeah, if we get that right, we're working the foundation.
Exactly.
And understanding that a significant numbers of your first responders are going to be uncomfortable will be a major thing to understand that we can start to try and rectify. We may not get perfect, but we can maybe take that 63% and reduce it to 25, something. I think that's a really interesting point. And again, if anybody who's involved in planning on that, that's something we can really take and work on. It's a specific area that we can improve. As to say, you've got the studies. If okay, I'll get the references off you. We can publish these with the podcast so people can access that information as well. Good, fantastic.
Sure.
Let me just ask you one more question. One question we ask every guest that comes on TSG Talk, and we get many different answers. But if you were to take one piece of medical equipment with you anywhere, what would it be?
You know, the first thing I would take if I had one piece, and that would be a defibrillator. I can't
Okay.
recreate electricity.
Uh-huh.
If you're looking for something smaller, it'd be a tourniquet. And I can make a tourniquet. I can't make a defibrillator.
Okay.
But yeah, something like if you think about ABCs, what are the things we're going to do to correct that? We can position a patient, but a defibrillator would be the first thing.
Okay. And I suppose with the defibrillator, you're going to get monitoring as well with the modern ones. So you get a double hit on it.
Yeah, if I can't do anything else other than shock a non-beating heart,
Hmm.
that's not. I can't use a jumper
Hmm.
cables to do that.
Hmm. Hmm.
It's only something that's available with a defibrillator.
Hmm.
But just something simple. I have tourniquets and every bag that I
Mm.
own and every
Mhm.
car that I own. There are little things we can do if we want to live a prepared life, if we want to live the life that we preach for others to do,
Mhm.
we need to do it ourselves.
Yeah, no, that's a very good answer, and thank you. And I think you're the first person to do fibrillator. I think we're
Okay.
on sort of episode 25 now at TSG Talk, and we get different answers from everybody. And we're actually writing up a mini paper on what we're
Okay.
calling just one thing. And it's fantastic to see what people have picked and why they pick it within their environments. It's actually really interesting. So no, thank you for that answer. So Randy, look, it's been absolutely wonderful this afternoon to talk to you. I learned a lot about this subject, and I'm sure our listeners have really picked up some points that they can take into the planning process and the preparation areas to make them better when they're faced with these complex incidents. So look, thank you so much for your time. It's been an absolute pleasure. This edition of TSG Talk, we'll put this on all the major podcast sites and also on our website at tsgassociates.co.uk. If you like it, please subscribe and like, and we always like a 5-star rating, so that would be much appreciated. So thank you everybody for listening, and Randy, thank you once again for a really informative talk that I'm sure our listeners will find of great value. Thank you very much.
Thank you.
Thank you for taking the time to listen to this edition of TSG Talk. We hope you found the content of benefit. Should you have any questions or require additional information, please visit tsgassociates.co.uk.